Good morning or good day to everybody. My name is Tatiana Reich and I'm a new president of the European Liver Patient Association. I'm very glad to see so many people at our second symposium during this very important Congress, annual EASL Congress. So we as ELPA are very grateful to be hosted at this Congress and having an opportunity to hold this symposium and present to you, in our opinion, very important issue. This is a perfect example how great cooperation between patients and medical experts can bring us to important achievements and results that we think will, in the future, will to us patients bring more benefits. So that's all from me. Dr. Martin Schäfer will continue, and thank you once again for being here today.
So thank you for being here. It's very nice to see that so many people are interested to join this very important workshop or conference. And the title is Fighting the Shadow, Hepatitis C and Mental Health. And what we want to do, we want to present you some results from our European ELPA expert workshop that took part yesterday. We sat together to discuss how to care for patients with mental health problems during hepatitis C infection and antiviral treatment development of European expert guidelines. So what was the aim of this? We discussed with the ELPA, we was invited to discuss this very interesting topic, and we were asked to review the scientific data and discuss our experience in the treatment of hepatitis C related psychiatric problems, and to discuss the impact of hepatitis C on the brain, the impact of pegylated interferon, ribavirin and the new antiviral substances, and most importantly, how to help patients who suffer from the symptoms. So why do we need such expert recommendations? Why do patients need that expert recommendation? We think that patients and clinicians should have a consensus paper that summarizes current knowledge. Patients and clinicians should know treatment and preventive concepts for interferon-related psychiatric side effects. Patients often need literature that can be cited for their insurance, at least in Germany, to receive rent or pension, or to clarify if depression, fatigue, lack of concentration might be associated with chronic liver infection. And patients also often need support to prove that depression, cognitive disturbance, or other symptoms might be related to the interferon alpha treatment. So we had the great pleasure, or I had the great pleasure, to find very good and excellent experts from all over Europe who has published numerous papers in this field. They're real experts, they're hepatologists and psychiatrists, psychologists, and we also had Achim Kautz from the German Liver Aid, as he represents ELPA, and who discussed with us. Let me just shortly introduce the experts, starting with Lucille Caperon, who is from Bordeaux in France, who has also published numerous papers about interferon-related side effects. Astrid Friebe from the University Hospital Bochum, who was working together with me at the Charité Berlin. Carmine Pariante from the King's College of London, professor for psychiatry, and who has also published lots of papers in this field. Crisanto Diaz Quevedo from Barcelona in Spain, who just published a very interesting work about preventive treatment options for depression in hepatitis C treated patients. Myself, I came from the University Hospital here in Charité, Berlin. Now I'm working in Essen as a psychiatrist. But it's also important to have hepatologists to tell us what's important from the view of the hepatologist. And we're very proud that we have Gerd Robes from the University of Genk in Belgium. And he also has published very important work also for drug users who get treatment for hepatitis C. Sergio Neri from Italy, a hepatologist who did studies about psychotherapy, which is also very important for the patients, and Graham Foster, who will come later to this symposium, who's in London at the London School of Medicine, a very known hepatologist, and again Achim Kautz, who discussed with us as representative of the ELPA. And we were also very thankful that Simone Wittheim, as a medical journalist, were together with us, who will put this all together later on, this data. So we prepared several topics. We don't have too much time, so we have to present you the results of our discussion yesterday in 10 minutes, and then we have for each topic 5 minutes to discuss this topic. We start with HCV infection in the brain, then we come to prevalence, cause, and neurobiology of interferon alpha associated side effects. We thought that it was important to discuss risk factors for interferon alpha induced depression and suicidality. Then we focus on the management of HCV infected patients before antiviral treatment. Then we will talk about management of acute psychiatric problems during treatment. Then of the possibilities to prevent interferon alpha associated psychiatric side effects. And finally, we will talk about the new antivirals, which is very important to know if there are or will be some important psychiatric problems with this. So if you hear the levels of recommendation or evidence, just briefly, we have a recommendation level A, that's the best evidence, full evidence from high quality trials. There's a recommendation level B, there's sufficient evidence from open controlled trials or retrospective controlled trials. We have the level C, there's limited evidence coming from case series or case reports, and the level D, these are expert opinion coming from clinical experience, but we don't have trials so far about this. So just if you see in our recommendations the A, the B, the C, the D, so A is the best, but D is also important because it comes from the clinical experience. So let's start with the first talk, just have to find it, which will be held by Astrid Friebe from the University of Bochum. So I think you have to help me because I don't find it. So she will talk about a very important topic, that is, what is the HCV virus doing with the brain? Astrid, please.
Thank you very much for the introduction, and I also would like to start to say thank you to the ELPA for organizing this kind of symposium. And it was a pleasure for me to be invited and to attend the workshop yesterday. And I'm happy to present to you now the summary of the results of the first topic, which is hepatitis C infection and the brain. So I have nothing to disclose. I will start first with a summary of the current literature about the psychiatric comorbidity which is present in hepatitis C infected patients. I will then second focus on the question if this psychiatric comorbidity is associated with a hepatitis C infection. Third, what is the impact on the quality of life? And finally, what evidence do we have for direct or indirect effects of the hepatitis C virus on the brain? So I start with the psychiatric comorbidity. And in this slide, you see a summary of multiple studies who have all investigated the prevalence rates of several psychiatric diseases. And as you can see, in hepatitis C patients, there is increased prevalence of depression, of anxiety disorders, of bipolar disorders, of schizophrenia. We have also a high proportion of alcohol abuse and dependency. And of course, we have also a high proportion of other drug use, which includes the intravenous drug use due to the transmission route of the virus. And we have also a high proportion of fatigue. It's not a disease, but it's also a very frequently reported psychiatric symptom. Another frequently reported symptom by patients is cognitive impairment. There are also several studies in the past who have investigated this issue and who have done neurocognitive tests with untreated hepatitis C patients in comparison to healthy controls. And all of these studies eventually found, at least in some of the applied tests, significant impairment. So we can summarize the results that there seem to be significant cognitive impairment in hepatitis C infected patients. And to roughly summarize the quality of the impairment, it is kind of attention, concentration, and memory deficits. So we draw our first common conclusion, which is psychiatric comorbidity is significantly more prevalent in chronic hepatitis C infection than in the general population. And this leads me to the second point. The question is this psychiatric comorbidity cause or consequence of hepatitis C infection? And regarding this question, we have to look at the prevalence rates of hepatitis C in certain risk groups. And as you can see in this table, we have the prevalence of hepatitis C of around 1.8% in the general population. And as you see in the general psychiatric population, this prevalence is much higher, ranging between 6.7 and 8.5%. And of course, we have a very high amount in intravenous drug users. So to explain these numbers, there are studies indicating that patients with psychiatric disorders may have an increased risk for getting infected with the hepatitis C virus. This can be, for example, to have an increased risk for becoming drug user or high-risk drug user, which is related to diseases like depression, bipolar disorder, or schizophrenia. So this means that due to this reason, we might have an accumulation of psychiatric diseases in the population of hepatitis C patients. So the second conclusion that we draw is psychiatric morbidity is associated with an increased risk for hepatitis C infection, and this may be related to increased risk factors that are leading to infection, for example, drug abuse. But on the other hand, there is also some evidence that at least for some psychiatric symptoms, that there might be a special association with the hepatitis C infection. And for example, this study compared hepatitis C and B infection in a population of patients where confounding factors, especially drug and alcohol abuse, have been excluded, and they showed that depression was significantly more prevalent in hepatitis C infection, but not in hepatitis B infection. So depression might be also specifically associated with hepatitis C. And such evidence we have also for other symptoms like fatigue. Summary of the literature says that fatigue used to be unrelated to the severity of liver disease, and it is also more prevalent in hepatitis C than in hepatitis B patients or in other kinds of liver disease. And there is evidence that fatigue improves after successful treatment. The same evidence we have for cognitive impairment. Also, cognitive impairment seems to be unrelated to the severity of liver disease. It is independent of the history of substance abuse or other psychiatric comorbidity, and patients successfully treated show less cognitive impairment. So we concluded that some psychiatric symptoms, especially depression, fatigue, and cognitive impairment, occur more prevalent in hepatitis C infected patients, which is independent from psychiatric comorbidity and seem to be specifically associated with chronic hepatitis C infection. So now I come to point 3, the impact on quality of life. This is an issue which has also been well investigated over the past, and just as an example are here presented the results of one study of the SF36 questionnaire, which is a questionnaire to measure quality of life. And as you can see, in hepatitis C patients, all dimensions that are measured by this questionnaire are significantly impaired. Then the second important issue is stigmatization perceived by patients. Here are the results of one study which specifically investigated this issue, and they were asking patients for their experience when they went to a physician, for example, a dentist. And here, nearly 40% of patients experienced at least one incident of stigmatization that was related to their HCV-positive status. And stigmatization was categorized, for example, as treatment denial, as a change of treatment plans, a referral to colleagues, an overcautious behavior, hostile or declining physician, or negative behavior by staff members. So here we can conclude that chronic hepatitis C infection leads to a high degree of psychological distress, which includes stigmatization, anxiety, and a reduced quality of life. And we also said that improving coping strategies could be important to reduce psychiatric symptoms. Okay, now we come to the last point. What evidence do we have for direct effects of the hepatitis C virus on the brain? Here I start with a summary of studies that were using magnetic resonance spectroscopy, and there were several studies published, and to very shortly summarize the findings, all of these studies reported significant alterations in brain metabolism, and the studies concluded that these alterations they found were indicated of an inflammatory or infective condition, and possibly to an activation of microglia cells in the brain. So these studies indicate that there is an involvement of the CNS, which can be explained as well by a direct effect of the virus, but also by indirect effects, for example by an elevation of immune mediators and cytokines from the periphery. Then there was one SPECT study which showed that hepatitis C infected patients, in comparison to normal or healthy controls, had significantly diminished dopamine and serotonin transporter binding activity, and that this was present in 50 to 60% of patients. And then, last point, what evidence do we have that the hepatitis C virus directly enters the brain? There are also a few studies and publications, and they reported that they found hepatitis C virus RNA in brain tissue from infected patients. The virus was also found in the cerebrospinal fluid, and the more recent publication indicate that the virus might infect microglia and macrophage in the brain, and that there is evidence for activation of these cells in the brain tissue. So these studies indicate that hepatitis C virus might also directly enter the brain and might replicate within the brain. So we conclude there is evidence that the hepatitis C virus affects the CNS directly or indirectly, and recent studies point that the HCV virus can enter and replicate in the brain. But even though there we have putative biological pathways by which the hepatitis C may lead to psychiatric symptoms, this causality has not been demonstrated yet. And as an outlook, we all agreed that we need more interdisciplinary data to clarify the causality of psychiatric symptoms and hepatitis C infection. Okay, and I'm happy to answer your questions.
Thank you for this
excellent summary of our discussion yesterday. So it's open for questions. Do you have any questions to Dr. Tribune?
Would you consider any of these contraindication to treatment or an indication of treatment for hepatitis C? And do we need to do any psychiatric sort of assessment or a pre-medication of psychogenic drugs before we start treatment?
You mean the treatment of psychiatric symptoms?
No. The presence of psychiatric disturbances that you just alluded to, are they a contraindication to treatment? And do we need to take any precautions, or are they an indication of treatment of hepatitis C?
I mean, if there is psychiatric comorbidity, it should, of course, be treated. For example, if there's depression, depression should be treated, especially as we will see in the next topics. If you're going to have the interferon therapy, it will be especially important to have these symptoms treated in advance. And this refers, of course, also to other psychiatric comorbidity.
And are they the cognitive and the stigmatism and so on are going to severe treatment, or they are going to increase?
With a cognitive impairment, it will be difficult. No, I think there's currently no specific treatment for these symptoms. It is just that the treatment, just a general treatment of the hepatitis C infection, and then they might be reduced, these symptoms.
But in some cases it might be also helpful to offer psychoeducation in advance to the treatment to improve coping strategies because of stigmatization or other problems. So thank you very much. More questions?
No, I saw something you wrote and it was by too quickly. What happened with the cognitive skills once the treatment was over, in case it was well succeeded?
Well, there are some studies reported that these cognitive impairment was better than before the treatment.
Better than before the treatment, but still not as good as before your illness. I mean, it was getting better, but not good.
Yeah, I cannot really answer yes or no. It was getting better, but we also have to consider that there might be also in the induction of cognitive impairment by interferon alpha therapy. So,
and the problem is that we don't have data what happens before the illness, so there are no trials comparing this. So it's a very important question. There were two other questions here.
More depression. You said that hepatitis C has got more depression as compared to hepatitis B. Is there any scientific reason for that?
that you have more depression in the patients. Yeah, the reason I think what I presented is that there's first some evidence that the depression might be associated with the hepatitis C infection directly. So that's why one reason that we have an increased rate. And the other reason is that I explained that people with psychiatric diseases might, or for example, people with depression might have an increased risk to become a drug user, and due to the transmission of the virus, then they have also a higher risk of acquiring hepatitis C infection. That this might be another reason why we have an accumulation of depression in this disease.
So, another question?
Hepatitis C causes cryoglobulinemia. Does the cryoglobulinemia has some relation with these CNS symptoms?
I cannot answer this question, but maybe one of the slides.
No, so far not known. So there are other problems with this disease, but not with psychiatric problems. Some more questions? If not, there's one question over here.
How do you know what was first? Most of the patients don't know they are affected.
Yeah, all the patients in these studies, they knew they were infected, and but of course it is always difficult to say what had been before the infection as symptoms and what not. So you have to use control groups to compare either healthy controls or patient groups that are similar except to the other group, except for the fact that they are not infected for the infection, so they're uninfected and uninfected, and you can just make statistical comparisons. But in the individual cases, it's of course difficult or it's impossible to tell what happened before and what is due to the infection.
Okay, thank you very much, Astrid, for this excellent talk. I switch to Camille Pariente, who will be the co-chair of this symposium and will introduce the next speaker.
Thanks, Martin. I'm delighted to introduce Lucille Capuron from Bordeaux. She's done some of the most important work in trying to understand the physiology of depression during treatment with the interferon alpha. And in fact, most of the remaining of the talk will be on interferon alpha induced depression and psychotic symptoms during interferon alpha. So the focus will now switch from hepatitis C itself onto interferon alpha. Thanks, Lucille.
Thank you very much, Camille, for this introduction. To start, I'd like to thank the ELPA and the organizer of this meeting and this very interesting workshop, Akim Coates and Martin Schaefer, for inviting me today and giving me the opportunity to present to you data regarding the prevalence, the time course, and the neurobiology of the neuropsychiatric effects of interferon alpha treatment. So I have nothing to disclose first, and so I'll start directly on the prevalence. So we know that interferon alpha treatment is associated with a large number of neuropsychiatric side effects, including depression. And depression, the prevalence of this disease depends on the severity of it. So as you can see on this slide, overall, 30 to 70% of patients with hepatitis C treated with interferon alpha develop depression during the treatment. And if we consider more particularly major depression, 15 to 44% of them develop this disease. Depression is the occurrence of depression during interferon alpha administration doesn't seem to be related to the type of interferon which is used during treatment, because there was no significant difference in the depression rate between standard versus pegylated interferon alpha, 2B, and the form of interferon alpha, 2B or 2E, doesn't seem to influence also the prevalence of depression during treatment. Depression is not the only effect, neuropsychiatric effect induced by interferon alpha, and as you can see in this slide, there are a lot of other neuropsychiatric effects induced by this treatment, including fatigue, and fatigue actually is the most prevalent effect, neuropsychiatric effect of interferon alpha. As you can see here, approximately 80% of patients develop fatigue during this treatment, and in this case, fatigue is from moderate to severe intensity. So this is really a big problem during the treatment. Sleep disturbances, irritability, anxiety, cognitive dysfunction, also very frequent. Between 30 to 40 to 50% of patients develop these symptoms during treatment. Then you have other types of symptoms that may occur during this therapy, including mania, psychosis, suicidal thoughts, and suicide attempts. But fortunately, they represent less of the population of patients treated with this therapy. So how do these symptoms develop during treatment? What's their time course? As you can see on this slide, there are different events that appear during this treatment. First, as soon as the first administration of interferon alpha, the cytokine, you can see flu-like symptoms developing in patients. This is mostly fever, pain, headaches in this patient. So these symptoms are really appear very quickly during treatment, but they usually resolve easily. Then you have two types of neuropsychiatric symptoms. The first type concerns the neurovegetative symptoms, what we call the neurovegetative symptoms, fatigue, anorexia, psychomotor slowing. All of these symptoms develop at early stages of interferon-alpha treatment, and they remain present during the whole duration of the treatment. So fatigue, for instance, is frequently observed during the whole duration of the therapy. And these symptoms develop in a large proportion of patients, as I told you before. A second type of symptoms, which concern more the mood and cognitive features, and particularly depression, develop later on during treatment, and usually between week 10 and week 20 of treatment. And as you can see here, the maximum depression score are measured between this time course, so week 10 versus week 20. So most of the psychiatric side effects of interferon-alpha treatment occur between weeks 10 to 24. The prevalence of this psychiatric effect remains present sometimes during the whole duration of therapy, but what is interesting here is that if we compare the prevalence of psychiatric side effect at week 48, we don't see any significant difference with the prevalence measured at week 24. So they remain present, but they are not most present. And major depression is still present during treatment and at later stages of treatment between week 24 and 28 of treatment. So what happens after treatment cessation? So when we stop the treatment, does the symptom remain present? So usually the psychiatric side effects disappear between 3 to 12 weeks after treatment cessation. Nevertheless, in some patients, in single cases, have described the possibility of persistent symptoms, recurrence of depressive symptoms, and even the new development of depression and cognitive disturbances after treatment cessation. So the question which interests particularly neurobiologists and biological psychiatrists is the way these symptoms develop. What is the neurobiology of the symptoms? How the cytokines that we administer peripherally to patients is able to induce depression and neuropsychiatric disorder, what happens in the brain of patients who receive this type of treatment. So we know that interferon alpha, which is administered peripherally, is able to activate the innate immune system, and the activation of this innate immune system is accompanied by the release of proliferatory cytokines, including interleukin-6, interleukin-1, and TNF, and tumor necrosis factor alpha. These cytokines, by different mechanisms that I'm not going to describe today, are able to reach the brain, and within the brain, they are going to activate the neuroendocrine system, but also they are going to modulate the synthesis and activity of the neurotransmitters, and particularly dopamine and serotonin. So there are different, if we consider first serotonin, because serotonin is a major neurotransmitter involved in the regulation of mood, and particularly mood disorder, including depression. So if we consider serotonin, we believe that the alteration of this neurotransmitter may be responsible for the development of major depression in patients treated with interferon alpha. And indeed, this hypothesis is supported by the fact that interferon alpha, like every other cytokine, is able to induce the enzyme IDO, which is endolamine deoxygenase, and this enzyme, when it is induced by interferon alpha, is able to induce the degradation of tryptophan into a neurotoxic pathway, kynurenine and kynureninic acid pathway. So this pathway is neurotoxic, is associated with significant neurotoxic effect, and the activation of this pathway by IDO is detrimental to the serotonin pathway. So when interferon alpha is administered, tryptophan is degraded, and therefore it becomes less available for its conversion into serotonin. So basically, in patients who receive interferon alpha treatment chronically, there is a serotonin depletion because there is no transformation of tryptophan into serotonin. We try to confirm this possibility in patients treated with interferon alpha. In this study, patients received high doses of interferon alpha. And as you can see here, tryptophan depletion occurs very rapidly during treatment. As soon as the 5th day of treatment, you can see that tryptophan levels are really decreased compared to baseline values. And this decrease remains persistent at the end of the first month of treatment. What is very interesting for us here is that these decreases in tryptophan are associated with the development of depression, and particularly with the depression score that we measure in this patient using the Montgomery and Asper depression scale. But here in this part of the slide, you can see that finally tryptophan depletion occurs in almost every patient treated with interferon alpha. But this depletion remains persistent at week 12 of treatment only in patients who develop depression. So this is a fundamental apparently mechanism in the development of depression in patients treated with interferon alpha. And this degradation of tryptophan, conducting to serotonin depletion, is more particularly associated with the mood and cognitive features of depression in patients treated with interferon alpha. They are not associated with neurovegetative feature, including fatigue. So fatigue may rely on different mechanisms. And one of these mechanisms that may be involved in the development of fatigue may be the alteration of dopamine and the alteration of the activity of brain areas that are related to the synthesis and metabolism of this neurotransmitter dopamine. So we assess this possibility in 12 patients treated with high dose of interferon alpha. Here they are malignant melanoma, but this has been confirmed in patients treated with lower dose of interferon alpha for chronic hepatitis C, and we have absolutely the same picture. And as you can see here, is that interferon alpha administration, here it's only for 4 weeks, is associated with significant changes in brain activity, and in the brain activity, and particularly in region which are related to the basal ganglia, related to dopamine function. So you have the striatum, the pallidum, you have a little bit also of the thalamus in this patient, and also the cerebellum. So this metabolic activity in this region is increased by interferon alpha treatment. And very interestingly, we obtain exactly the same picture in patients with Parkinson's disease. So we know that Parkinson's disease is associated with hyperfunctioning of dopamine. But if you do a PET study measuring metabolism in this region, you also have an increased metabolism of dopamine in this area of the brain. So that may explain why few patients, and some, not few, but some patients treated with interferon alpha develop motor symptoms, complain from motor symptoms or rigidity, but also psychomotor slowing during treatment. And in fact, what is interesting is that this alteration in the basal ganglia, probably related to dopamine dysfunction in this, due by interferon alpha treatment in this patient, is associated with the development of fatigue in this patient. Here we have the score of energy. Decreased energy is associated with increased metabolic activity in the accumbens and putamen, so it is striatum on this patient. But if we use different scale of fatigue, we have similar results. So to conclude, we can see from all of this different data and the synthesis of the literature that treatment with standard or pegylated interferon alpha, either the form 2E or 2B, is associated with an increased incidence of mood alterations, including depression from mild to severe intensity. Fatigue is also very present in patients treated with interferon alpha, and but also sleep disturbances, irritability, cognitive dysfunction, suicidal thoughts, and suicidal ideation. Treatment with standard and pegylated interferon alpha, always the two forms, A and B, is less frequently associated with mania, acute confusional states, psychotic syndrome, suicidal attempts, and impulsive aggressive behavior. It's less frequently, but it may be associated with the symptoms. Neurovegetative symptoms, including fatigue, sleep disturbances, decreased appetite, and psychomotor slowing, start immediately after treatment, whereas depression and cognitive disturbances usually start later, mostly between week 4 to 24 of treatment. Depressive symptoms are the most intense between week 8 and 12 of interferon alpha therapy, and usually psychiatric side effects, including depression, improve when you stop the treatment. However, in some cases, psychiatric symptoms can persist. This is the case for depression, fatigue, and cognitive disturbances, or even newly developed after treatment cessation. Treatment with standard or pegylated interferon alpha is associated with peripheral and central immunological changes, I didn't show all this data, but we have strong evidence for that. Hormonal and neurobiological changes, I focus mostly on that today. And this alteration, primarily in serotonin and dopamine metabolism, may be related and seem to appear to be related to the development of depression and fatigue. The activation of the enzyme IDO, specifically by immune factors, including interferon alpha, results in serotonin depletion in this patient, but also activate, remember I just used this picture, a neurotoxic pathway that may be associated and related to the development not only of depression, but also cognitive dysfunction that frequently relates to neurotoxic mechanisms. I will stop here and I will be happy to answer your question. Thank you very much.
Any questions from Dr. Brown? Yes?
How many of the patients with psychiatric side effects get adequate therapy? Are there statistics?
Lucy, could you repeat the question?
How many persons with psychiatric disorder treatment that gets adequate therapy for these symptoms?
Maybe this is something that we can discuss. Can we pick up these questions again later, because we're going to talk about treatment and we're going to present some evidence then. Question from Dr. Kapura? Yes?
Yes, I see you're getting out from 6 months of treatment, but most of the times the type of depression, which is not acute, but which is social phobia, and hearing problems, and all these things, they kick in after 24 weeks. They kick in the 6 last months.
Yeah.
So, I mean, how much? A lot of these things, I think they get much worse during the last time. Do you have any idea?
Yeah, that's true. Because of the time, we just decided to focus on depression and early stages of treatment. But you're right. That's true.
Please?
My question is regarding the persistence of the neuropsychiatric symptoms after stopping the treatment. The mechanism is still cytokine medication. The mechanism is still cytokine medicated, increasing the interferon and the same mechanism, or do you think there is underlying neuropsychiatric disease prior to treatment?
So there may be different mechanisms that may be involved. It's true that inflammatory processes are related not only to the treatment that you administer, but also to the disease may be involved in the development of neuropsychiatric symptoms after treatment, or the persistence of these symptoms. But I think there is an interaction between these immunological and neurobiological processes, but also a vulnerability that some patients may have, and we will discuss further this issue in the next topic. But I think they don't develop in everybody, so there is probably this factor of that.
I'm afraid we have to move on to the next speakers because we are very tight for time. Perhaps we can ask for more questions later. Sorry.
Well, the next speaker is Camille Parianta, coming from London. He knows the situation as a clinician, but also as an excellent basic researcher from this lab. We have lots of information about pathophysiology and risk factors, and he will talk today about risk factors for interferon alpha-induced depression and suicidality.
Good morning, everybody. I'm delighted to be here. Thanks to Martin for the introduction and to ELPA for this having organized this really good event. It's the first time that European experts try to get together and express some guidelines and kind of a consensus statement on the importance of mental health problems. What I want to do in the next 10-12 minutes or so is talk about, in particular, the risk factors for interferon alpha-induced depression and suicidality, which is the overall terms to describe both an increased risk of suicidal ideation, of suicidal ideas or suicidal acts. And the key question I want to answer is why some people develop depression during interferon alpha treatment and others don't. Because we know from the prevalence data that has been mentioned before by Lucille Capuron that 30–40% of people develop severe psychotic symptoms, moderate to severe, others don't, other people don't. So what are the potential risk factors? Before I start, I just want to mention that I have received some money from drug companies, but none of the data that we'll discuss today is related to this, and in fact this is really very small amount of money. I wish they would give me more, but they don't. So, perhaps the most important risk factors for the development of depression is what we call here baseline depression scores. So I will talk about the slide in a second, but the concept is that the higher your depression level before you start interferon alpha, the higher is the risk of you becoming even more depressed during interferon alpha. And graphically, well, first of all, this has been replicated by many studies, and graphically this is represented here by this graph. So this is the baseline depression scores using the Zoom scale. It's a self-administered rating scale for depressive symptoms. And this is the scale, the rating scales before starting interferon alpha. And this is the rating scale, the maximum scores reached during interferon alpha, so the worst, at the time which patients felt at their worst for the depression. And as you can see, there is a nice positive correlation. So the higher your depression score at the baseline, the higher you become depressed. This has been replicated many times. And this is, I mean, of course, this is important. We'll talk about later about pre-treatment and treatment of psychiatric symptoms before starting interferon alpha. The positive message is, however, that this may not be necessarily linked to a worse outcome. So if you look at patients with pre-existing mental health problems, patients that before starting interferon alpha already have a diagnosis of depression or anxiety, for example, and there's other data also for other forms of mental disorders, it's quite clear that if you look at the overall outcome in terms, for example, of interruption of treatment, then the outcome is not changing. So this last year's work that we published more than 10 years ago now is what we call a survival curve, which is simply every time that the patient stops interferon alpha treatment, the line goes down. And as you can see, the line for patients who have a pre-existing psychiatric diagnosis, so they're already depressed or anxious before starting interferon alpha, and the line for those who actually had not psychiatric diagnosis before starting interferon alpha, the two lines overlap quite nicely. So yes, baseline mental health problems are a risk factor for developing depression during interferon alpha. However, not necessarily this relates to a worse outcome of the treatment overall. Now, why depression before interferon alpha is important in terms of what happens during interferon alpha? Well, there's many mechanisms proposed. One of it is that the depression actually measures your baseline level of overall stress and social support. So we have data that if you have higher baseline level of stress or if you have low level of social support, then the risk of becoming depressed is more elevated during interferon alpha, although these are data predominantly coming from the melanoma and the cancer literature. It is also possible that it is not depression overall per se, but there are only specific symptoms that increase your risk for developing depression during interferon alpha. And in particular, if you have sleep disturbances before starting interferon alpha, that seems to be perhaps a biological marker of a risk factor. And also, if you develop sleep and appetite disturbance early in the interferon alpha treatment, so if you have particularly bad reaction with sleep and appetite during the first week or a couple of weeks, then you're more likely to become depressed during the remaining of the treatment. Now, of course, when you look at risk factors and you think that interferon alpha is a powerful biological treatment, there's a lot of consequences, and Dr. Kagurane has illustrated how the interferon alpha can affect both brain function and the immune system and the communication between the two systems, then it's perhaps not surprising that either genetic factors that regulate the brain function and the immune system or biological measures that you can measure in the plasma, which again relate to the immune system, are important risk factors that you can look at that before starting interferon alpha and can predict who will later develop depression. Now, there's been a lot of data on genes, and I will not have time to review all of this. I will show some data in a moment, but I think what is interesting is that both genes related to brain function, such as the serotonin transporter, which I'll show data in a moment, but also genes related to the immune system, interleukin-6, COX-2, PLA2, and interleukin-28, they're both being related as a risk factors for specific allele and being related as a risk factor for interferon alpha-induced depression. The interleukin-28 is particularly interesting because it's a gene that is also regulated to the response of the virus to the interferon alpha treatment. So I just want to give you an example. The serotonin transporter is a very important gene for psychiatric research, and it is a gene that has been linked to increased risk of depression in a variety of conditions. So not only for interferon alpha, but in general depression, especially depression in response to stressful situations and stressful events. So it's almost like interferon alpha mimic biologically what happens if a patient has a really strong psychosocial stressors. And here you can see that if you have the bad allele of the serotonin transporter, what we call the SS, the black line, you have more depressive symptoms throughout the treatment, throughout 24 weeks of treatment. Now, the same for the interleukin-6 gene. Again, this is data that we published a couple of years ago. So there are various genetic variants for the interleukin-6 gene, one of which predispose to a lot of interleukin-6, so lots of activation of the immune system. And if you have that, so if you have more activation of the immune system, then you have more depression throughout the 24 weeks of interferon alpha. What is also interesting is that you have also a group of people that clearly have all the, if you like, all the good genotype. So there's a group of people, which here is in the dotted line, which have the good serotonin transporter gene and the good interleukin-6 gene, and they don't develop depression at all. In fact, they actually get better toward the end of the treatment. So the genetic factors are really important in at least allowing us to understand who, if anything, is resilient to interferon, and so it perhaps guide us more in personalized and individualized management. I've mentioned this before, so clearly because of the importance of the immune system, you can measure baseline levels of mediators that regulate immune function. So this is, again, before you start interferon alpha treatment. And if you have high level of pro-inflammatory cytokines, interleukin-6, virus-soluble receptors, you have more risk of developing depression. Also, if you have low levels of anti-inflammatory biomarkers, so if you have low level of things that would keep your immune system under control during interferon alpha, then you also develop more depression. IL-10 is a typical anti-inflammatory cytokine. We also published some data on omega-3 polyunsaturated fatty acids, which are considered anti-inflammatory. And so if you have low level of polyunsaturated omega-3 polyunsaturated fatty acids before starting interferon alpha, you're more at risk of developing depression, which again, it could be interesting in terms of using a nutritional intervention as part of the management. So let me just conclude. What is the evidence, the summary of the evidence? Well, I haven't mentioned this, but this is perhaps one of the most important risk factors. If you have developed depression during previous treatment with interferon alpha, you're very likely to develop it again, so this is quite strong evidence. Depressive symptom, as I said before treatment started, is a risk factor for developing depression, although from the positive point of view, this is not necessarily related to the overall outcome in terms of interruption of treatment. If you have sleep disturbances before the treatment, this is also linked to a risk of developing depression. Or if you develop what we call vegetative symptoms, so sleep problem, loss of appetite right at the beginning of the interferon alpha, with the first 1 or 2 injections, then you're more likely to develop depression. If you have baseline stress and lack of social support, this is one of these factors. And then there are both genetic factors and biomarkers that you can measure in the blood before starting interferon alpha, which are related to the immune system and you measure the stress of the risk. I just want to conclude with 2 slides on suicide risk, because I think it's very important that we kind of clarify some of the myths that are around. First of all, unfortunately, because of the high comorbidity between hepatitis infection and psychiatric morbidity in general, suicide risk is elevated in patients who are infected with chronic infection, in the same way that it is elevated in other chronic medical conditions. And the risk factors in general are the same that are associated with all, if you like, risk of suicide. So, using a drug intravenously or having a psychiatric comorbidity. So on top of this increased risk, does interferon alpha induce any more additional risk? I think that's the key question. And the answer is probably not such a strong effect. Now, of course, if with all depressive symptoms going up, during interferon alpha, as part of the depression picture, there will be some suicidal ideation. Thoughts like, perhaps life is not worth living. Most of the time they're transient, and they're also typical on any forms of depression. So these are thoughts that any depressed patient will have. So there is an increase of suicidal ideation in those who develop depression during interferon alpha. It is true. But the positive message, again, is the actual number of people who commit suicide during interferon alpha has been very, very small. Very small. We're talking about a handful of cases in case reports, even when you retrospectively analyze thousands and thousands of cases. So the relative risk is basically unknown whether interferon alpha increases the risk, because there is already, if you like, a higher risk to start with, and the actual occurrence during interferon alpha is very, very low. What is also important is that we haven't been able to identify yet specific factors for risk of suicide during interferon alpha, but there is no evidence that having a psychiatric morbidity before puts you at particular risk of the suicide act. So within the small evidence that we have with case report and retrospective assessment, most people who have committed suicide, I repeat, of the handful of people who have committed suicide during interferon alpha, none of them would have a pre-existing psychiatric comorbidity. So I think this is very important because, again, we have a lot of problem with patients with a previous history of psychiatric problem, perhaps a previous suicidal attempt, you mental health problem 10 years before, being denied interferon alpha treatment. So as part of the guidelines that we try to spell this out very clearly. And with this, I conclude and I'll thank you for your attention.
Thank you for coming for this excellent talk. Are there questions? Yeah.
How do you measure the grade of depression? Is it an hermeneutic way, or how do you measure depression? How can you say one is more depressed than the other?
So you can do it in a variety of ways. There are scales that we ask patients to complete on their own, just by ticking boxes, and it gives a degree of, for example, I feel sad every day, I feel sad overwhelmingly every day, and I cry all day, for example. So there are different degrees, like I have less appetite than usual, I hardly eat at all. If my sleep is disturbed, I don't sleep at all. So there are scale like this, which can be measured either by the patient, can be completed by the patient, can be asked by the doctor as well. So there are ways of standardizing the assessment and having a score, basically.
But I mean, it's very personal how you respond to these questions. Because somebody who's sleeping a little bit, I mean, one person has the impression of not sleeping at all, and another one says, oh, I'm sleeping quite well, and they sleep the same amount. So
I agree, and I think, again, we have to work with the tools that we have. I mean, but also I think sleep in particular, there's an element of objective measurement of sleep, which perhaps requires laboratory and kind of continuous monitoring. But there's quality of sleep, which is perhaps more important for depression, which actually, the subjective interpretation is perhaps even more important than the amount of hours that they sleep. But the only things I can say is that the instrument that we have as psychiatrists, they're actually very, very well validated. They've been used in thousands of patients with multiple conditions, from medical disorder to traumatic psychiatric diagnosis, in clinical trials of antidepressants, and they are very reliable. They're as reliable as having an MRI scan or X-ray or blood test.
So, if there are no more questions, there's one.
Previous suicide attempt, how much rating was that? Previous suicide attempt, how rating do you rate that? How do you rate that in this factors?
I mean, as I've said in the last slide, it's very difficult to rate it because if it's the previous, I mean, we'll talk about it a little bit more later, but the previous history of psychiatric problem only seems to be relevant if your mental state is still affected. So we're talking again about little data, but people with a previous history of depression, including previous history of suicide, which may be 10 years before, and they're currently well, they do not seem to be at any higher risk. And so I think of developing interferon alpha-induced depression. Certainly there's no evidence that the previous episode of suicide attempt predict another suicide attempt. There isn't. So So I think, of course, as a clinician, you want to be particularly, and we discussed about the management, you want to be particularly careful with patients that are more vulnerable, they have a difficult situation or a previous history, you may want to give extra support. But certainly there is no indication for not giving the treatment.
Okay. Final question, please. Short answer.
Sami Bouskaya, I'm a pathologist in Paris. You say that depression may be linked to higher inflammatory pathway activation. Is there some clue that link psychiatric side effects to sustained virologic response? I mean, if there is more psychiatric side effects or more inflammatory response, is there a higher sustained virologic response, for instance?
The data is very conflicting. So we have published one study that showed that if you have depression, your response is less. Other people have shown that if you have depression, your response is not affected. And there's the confounding effect. If you have depression, most of the time you're on the clinician will also start an antidepressant. So the issue is, is the antidepressant confounding. So basically there's no data. There's definitely no data to say that antidepressant treatment are bad for your response. So there's no reason that you should not receive treatment. So antidepressants do not reduce your response. But there's no clear data whether depression in itself has an effect.
Even if you compare with sometimes when you are depressed, you most often you decrease doses of interferon and you can spare doses. Maybe it's.
So there's not such a strong data. I think there is some evidence that there may be an effect which could be indirect to reduce compliance. So definitely there is a possibility that if you are depressed, your response becomes less because maybe your compliance with interferon is not as good. But again, it's not, the studies are not very strong.
Yeah.
Thank you.
So we have to continue. Thank you again. The next speaker is Gerd Roberts. He's professor of hepatology working together at the University of Leuven in Belgium, and he's a hepatologist who's very interested in this mental health problem and areas, and he will tell us something about the management of HCV-infected patients before antiviral treatment.
Good morning. First of all, I want to thank ELPA and Dr. Scheffer for inviting me for being present in this excellent symposium. I want also to thank the other faculty members for the excellent discussion we had yesterday. I was asked to see as a hepatologist everything what we have heard up to now, and how to manage people who are infected with hepatitis C virus before antiviral treatment, and this focusing on mental health problems. This is my disclosure slide. After a long discussion, we think it is necessary to check the psychiatric history, the current or former history of drug addiction, and history of suicide attempts. In case of psychiatric comorbidity or drug addiction, it is very important, it is necessary to organize an interdisciplinary treatment and to send, as a hepatologist, a patient to the psychiatrist or the addiction specialist before treatment is started. And it is also necessary to provide information about the possible psychiatric side effects and the different treatment options. It is also recommended to screen for possible psychosocial problems, this concerning job, family, social context, coping with the disease, all things which can be influenced by having been diagnosed hepatitis C or being referred for antiviral treatment with interferon and ribavirin. It is also recommended to involve a confidant, a family member, friends who help patients during the treatment of hepatitis C. And it is also important to train the patients to monitor their mood changes and how to use self-rating skills. The definition of depression is classically for psychiatrists based on the DSM-4 criteria and is consisting of a depressed mood and or loss of interest that persists for more than 2 weeks. And this can be associated with, you saw already from the previous speakers, that in the first part neurovegetative symptoms occur and later on cognitive symptoms. So it is important to screen for change in appetite or weight, changes in sleep, insomnia, hypersomnia, fatigue, loss of energy, psychomotor agitation and perturbation, and later on for worthlessness and or feeling guilty, decreased concentration, and suicidal ideation. This can be screened more easily by depression rating scales, and there are rating scales which can be filled out by the patients themselves. These are self-report rating scales, and there are also rating scales which are administered by the clinicians. And this can help us to make a diagnosis of depression in a very early stage. It was studied that looking for change in vegetative symptoms only 4 weeks after starting treatment with interferon can be predictive for the evolution to depression defined by DSM-4 criteria afterwards. And this gives the possibility to start antidepressive treatment in an early phase of the disease. How can suicide risk be screened? The best method at this moment is to ask directly to the patients if there have been problems in that sense, personal, in the family, or in the case of pre-existing aggressive disease. And this especially during the first 12 weeks of treatment with interferon. When do we, as a hepatologist, have to refer the patient to a psychiatrist? Certainly when there is a situation where the primary physician, the hepatologist, is not comfortable managing patients' depression. Also when the diagnosis is uncertain or complicated by other psychiatric factors. When there is an identified or a suspected risk for suicide. When there is an alcohol or substance abuse problem. When the social situation is complex, or when the management is complex, the response to medication not optimal, or when it is considered to prescribe multiple agents. Also when psychotherapeutic treatment is required. When might patients be hospitalized? This in the case of high risk of suicide, in the case of lack of response to appropriate therapy, when any psychotic symptoms significantly affect the patient's thinking and behavior, in the case of disorientation, and when delirious symptoms occur. Must antiviral therapy be stopped? Not from the start. The continuation of the antiviral therapy can be, the antiviral therapy can be continued despite psychiatric side effects, and this should be discussed between the hepatologist and the psychiatrist, and this on a case-by-case decision. How to manage during and after antiviral therapy? It is very important to look for mood changes. They should be monitored every month in the first 3 months of antiviral therapy, and then at least every 3 months. In case of psychiatric comorbidity or drug addiction, patients should be screened more frequently, and this already after, this every 2 to 4 weeks during the first 3 months of antiviral therapy, and then more frequently every 4 to 6 weeks. Psychiatric changes must also be monitored after therapy, this during a period of 1 to 3 months, and in the case that psychiatric side effects occur, they should be monitored during a longer period, 12 to 24 weeks after antiviral treatment. What about patients who have been infected after substance use? Can they be treated with the same medications as other patients? The answer is yes. They can be treated with the currently approved regimens. They have no increased risk or decreased risk for sustained virological response. There is no change in the occurrence of severe depression during treatment, and there is no chance for a higher mean increase of depression scores. Also, for patients with a pre-existing psychiatric problem, they can be treated using the currently approved regimens. There is no influence on early antiviral treatment discontinuation. There is no lower compliance. There is the same sustained virological response. There is no high risk for severe depression during treatment, and there is no change in mean depression score. What might be relative contraindications requiring individual treatment decision? Patients who have acute, major, and uncontrolled psychiatric disorders. Also patients with active, ongoing drug use who have not been treated in a substitution program. To those patients, an interdisciplinary decision has to be offered, this together with a psychiatrist. And this must also be the case in the situation of difficult medical situations as HIV co-infection or dialysis. I thank you, and I'm ready to...
So, thank you very much, Gerd. Are there questions about the management before treatment? Yes, yes.
Well, at the end of treatment, we get either a sustained viral response, or non-response, or relapse, or whatever. Is there a difference between the psychiatric outcome between these less immeasurable sort of psychiatric outcome? Suppose we have put a patient on antidepressants because the patient is depressed during treatment. Once we finish treatment, how long do we have to go on antidepressants? And is there a difference between those who had sustained viral response or not?
Okay, the second question I will talk about in the next talk, I think. And the first question, if you know.
I think there is no relation between the outcome of depression and the outcome of antiviral treatment.
So there's one trial about this, and there's no association with antiviral outcome. Yes. More questions? So if not, thank you again.
I'm very happy to introduce the co-chair and organizer of this symposium, Professor Martin Schaffer. Martin is the head of the Department of Psychiatry in Hessen, and has been written some of the most important papers really on the treatment and management of patients with depression during interferon alpha.
So, thank you, Carmine. Thank again the ELPA for helping us to organize this meeting. I will talk about the management of psychiatric problems. Here is my disclosure. And I will start with some important points why we need a good diagnosis of depression and a good treatment. Here you see a trial with 325 patients receiving interferon alpha and ribavirin, and as you can see, 37% developed depression during this treatment. And what we could see from or learn from this trial that at least 1/3 were not diagnosed, did not get any treatment, and this was associated with a premature discontinuation of the therapy, and that's what we want to avoid. So the patient shouldn't stop treatment. We have to care for him that they can stay in treatment. So what can we do for the patients? We can offer them education, we can offer them good monitoring and neuro support. We can offer them information and psychoeducation before and during treatment. We have to monitor the patients during treatment, you heard this before, and we can give him some supportive psychotherapy, but we also have pharmacological strategies that are very helpful for the patient. And the most important is the antidepressant treatment in case of depressive symptoms, but we also have other symptomatic treatment options like antipsychotic, benzodiazepines, or other medication. And what we want to avoid is that the antiviral therapy has to be discontinued. So, how is this helping the patients? Here's a very interesting trial from Professor Neri from Italy, and he could show as a hepatologist that if you offer the patients psychotherapy once a month, that means a very good support during treatment, they could reduce the incidence of severe psychiatric side effects. In this group, you see there were 4.7% with severe psychiatric manifestation in the group. Without psychotherapy, this was 16%, and less of these patients with psychotherapy needed antidepressive treatment. However, this is not always going on like this, so psychotherapy cannot help all the patients because these are biological changes in the brain, but therefore, it was also important to show, this is from the group from Carmine Pariente, that if you offer the patients a consequent antidepressive or pharmacological treatment, they will have a better outcome. Here were 12 patients with psychiatric problems treated before and during antiviral treatment compared to 12 controls. And what they found was that the patients came out in a better way if they get a consequent pharmacological treatment, and this pharmacological management can successfully treat psychiatric symptoms in patients who are receiving interferon alpha. So again, this is a slide that there are two different time courses. We have an early time course of neurovegetative symptoms and a later on the development of depression. But what we can do and should do in the first 4 weeks is consequently treat early symptoms as far as possible, and the best thing to treat are the sleep disturbances. And we have the sedatives, the short and long-term hypnotics like zolpidem and zopiclone, what we use in most patients. And we have some data that if you treat this consequently, the sleep disturbance, you can also reduce sometimes the incidence of depression. There's another way to treat the sleep disturbance, which is very elegant. It's with mirtazapine. This is a sedative antidepressant, modern antidepressant that you can give in the evening, and you can reduce the sleep disturbance and possibly also reduce the symptoms of depression, but there are no trials so far on this. What do we know about antidepressants? There are a lot of open, uncontrolled data, case series. We know that all antidepressants are working in the treatment of interferon alpha-induced depression, but there's only one, but there is one prospective controlled trial that was done by Michael Kraus from Germany, and he could show that the antidepressant citalopram, this is a serotonin reuptake inhibitor, was able to reduce depressive symptoms in a better way than placebo treatment or non-treatment. And what you can see is after 2 weeks or 4 weeks, there was a significant reduction of depressive symptoms if you treat depression with citalopram. So, and what we also learned from the data from the literature is that interferon alpha depression is responding much better than normal depression treatment. So we have about 80% of patients who get a decrease of symptoms of about at least 50%. So this is a very good response in comparison to our normal treatment possibilities of depression. Regarding the side effects, there's no increase of side effects compared to other treatment forms in non-HCV infected patients. So there are typical side effects of these drugs, like sexual dysfunction, like headache, like gastrointestinal dysfunction, but this is not more prevalent than in the normal treatment. That's the question how long we should leave the patients on antidepressants, and as you know, that PEG interferon is still working even if you stop it after 2 or 3 weeks. We should leave the patients for at least 6 to 12 weeks on antidepressants. That is the better way to avoid recurrence of depression after the treatment. And there are some case reports that depression can also appear after the end of antiviral treatment. That's the question if antidepressant can influence sustained neurological response. So far there are no data supporting this. We can say from the current trials that there's no increase or decrease of sustained neurological response if you are on antidepressants. And here there are other forms of treatment if you have specific problems, but there are no trials available for this. So this is a treatment what we can offer the patients symptomatically, like for cognitive disturbance, craving, psychotic symptoms, irritability or fatigue. And this has to be discussed in each case with the psychiatrist. So how can we minimize suicide risk? And this we can minimize if we treat the patients early, if psychiatric symptoms can be screened, if even subclinically depressive or anxiety symptoms are treated, if mood changes and suicidal thoughts are closely monitored, and if the changes are treated promptly and consequently. And if suicidal ideation does not improve with treatment, the risk-benefit of continuing interferon alpha therapy has to be evaluated. So, in conclusion, depressive symptoms among patients undergoing HCV therapy should be covered by routine clinical interviews. The emergence of depression compromises the outcome of HCV therapy by early treatment discontinuation. Depression-specific symptoms are highly responsive to serotonergic antidepressants, and when selecting an agent, we have to consider what side effects are possible, what drug interactions are important for the patients. Consultation and follow-up with the psychiatrist is advised. And for the specific treatment, we found that early treatment of sleep disturbance is recommended from the literature. And the literature also says that first-line pharmacological treatment of depression should be done with citalopram, because we have most trial on this, but we also have case series for paroxetine, escitalopram, sertraline, mirtazapine, and other antidepressants, and this has to be discussed case by case with a psychiatrist. In case of depression, antidepressant treatment should be continued for at least 12 weeks after the end of antiviral therapy because of the long-lasting problems with pegylated interferon alpha. So for the treatment of other psychotic symptoms, including fatigue, anxiety, mania, irritability, psychotic symptoms, or suicidal thoughts, no data available so far. So patients need individual psychiatric management, and treatment should follow psychiatric standards and guidelines. So thank you for your attention.
What about prophylactic antidepressants prior to starting treatment? So actually starting antidepressant 4 weeks before you start the interferon. Is there any data for that? Would you recommend that as a strategy?
That's a very important question. It will be the next topic where we present the data on this.
I'd just like to give a comment. I come from Slovenia, Dr. Maticic. I'd like to say that psychiatrists in general are actually not very into details of the problems of HER2-positive patients and the particularities of their psychiatric problems. So, in my country, Slovenia, we found it extremely necessary to have subspecialized psychiatrists which are included into the team, interdisciplinary team, and actually it works.
prior it didn't work.
That's very important. That's the same situation in every country. We have specialized centers with very good psychiatrists in this field. But in my experience, it is important that you give some literature to the psychiatrist. He will read it, and it's not too complicated. He will understand it, and he will give you the best treatment.
I'm Stanimir Kasaji from Bulgaria. I would like to ask you if you're planning to have something like guidelines or interdisciplinary recommendations on managing mental disorders during and related with hepatitis B and C that could be widely distributed through specialists, both sides, hepatologists and psychiatrists, and also some guidelines for self-management of patients.
That's why we, so this is our conference, and we will try to publish it. Okay. Yes, and to also to prepare it for patients' guidelines, so that you really have something in your hand that you can give to the physician. But this was the aim of our conference here. Okay. Thank you.
Can I ask why you recommend more frequent monitoring for depression first 12 weeks of therapy, when we heard an earlier talk saying that it's actually more common between 8 and 20 weeks of depression?
So can you review?
Can you come here?
That's the microphone.
Sorry, can I ask why you recommend more frequent monitoring for major depression during the first 12 weeks of therapy, when an earlier talk in the session said that major depression is more common between 8 and 20 weeks?
Yes, it's the highest increase of depressed mood that you see later, but the development of depression is earlier, between starting with week 8. So we think you should monitor it and see it or diagnose it very early and then start treatment early. But there are no data so far which is the best time point, yeah, when you should start treatment. Most of the time patients come with clinical significant depressive symptoms, and then they are treated. And we are looking for a better time point, earlier time point, case by case.
So one more question there, and then we...
Are there any data on the combination of psychotherapy and pharmacological treatment? I think this we have a question.
Yes, that's always the best. If you can offer this, it's always the best, but there are no trials on it. But you can help the patients very quickly with pharmacotherapy, but you should also always offer psychotherapeutic support that is different from case to case.
Thank you. Can we move on? We are really tight with time. Perhaps we try to answer some more questions again if you have time. Can I introduce the next speakers? Dr. Crisanto Diez-Quevedo from the University of Barcelona, the Department of Psychiatry, who's done trials on prophylactic treatment, which is, as we were saying, the topic of this talk.
Good morning. I want to thank the ELPA for organizing this interesting meeting, and Martin Schaffer and Martin Couch for inviting me to participate in it. I'm going to present the topic of prevention of interferon-associated psychiatric side effects. This is my disclosure slide. You know that interferon alpha is associated with a high incidence of psychiatric side effects, especially depression. The first logical option to manage that is to treat side effects when they appear, but this approach relies on early detection and treatment, and when patients become depressed, they may also opt to discontinue interferon therapy before starting antidepressants. So a second option arises, that is to prevent side effects, but there's also some concerns about this approach. The unnecessary antidepressant treatment of in up to 60% or even more of the patients who are not going to develop clinically significant depression, and potential liver toxicity, additional side effects of antidepressant treatment, and their influence on the likelihood of sustained virological response. So I'm going to review all available data about this topic. The first mention should be done to the study by Musselman and colleagues published 10 years ago in melanoma patients. They showed that paroxetine pretreatment was able to to reduce the incidence of major depression, interferon alpha-induced major depression, and also to reduce the likelihood of antiviral withdrawal. After this study, up to 3 open-label studies have been published in chronic hepatitis C in theoretically psychiatric risk populations. A first study with 8 patients with a previous history of interferon-induced depression in previous antiviral treatments. A second study in 10 patients with previous history of major depressive disorder, but currently at baseline remission. And a third study with patients with a previous history of depression and drug addiction. In all these 3 studies, antidepressant pretreatment with SSRIs was able to prevent the appearance of interferon-induced major depression. The following step is to test this in prospective randomized controlled trials. Up to date, 4 studies, the first 4 ones, have been published. And there are also other 2 studies that have been presented at international meetings but not yet been published. In 5 out of these 6 studies, antidepressant pretreatment was not able to prevent major depression during interferon treatment. There's only 1 study by Martin Schaeffer and colleagues who was able to demonstrate a clear positive effect of escitalopram pretreatment in preventing depression during interferon treatment. But interestingly, in the study by Rayson et al., although paroxetine had no effect on depression in patients without baseline depressive symptoms, paroxetine was able to prevent depression in the subgroup of patients with baseline depressive symptoms, who scored above the median in the Montgomery-Åsberg Depression Rating Scale. And so that's all the evidence about efficacy. What about tolerability issues, safety issues in these studies? Regarding side effects, all studies have shown that antidepressant pretreatment did not increase the interferon side effects. Side effects were comparable between antidepressant pretreated patients and placebo pretreated patients. And all studies have shown that there was no influence of antidepressant pretreatment regarding the likelihood of sustained biological response. Numbers in parentheses are genotypes. But there are some methodological concerns in these studies. Some of them have small sample sizes. In most of them, 4 out of 6 of them, they found low rates of major depression, even in the placebo-treated patients. And there were different populations, different rates of previous histories of psychiatric and addiction disorders, and even differences in ethnicities of the population studies. And there are also some conceptual problems about these preventive studies. Which symptoms are we targeting for prevention? All studies have focused on depression, but we should consider other symptoms of distress also. And if focusing on depression, we should discuss if we focus on categorical diagnosis, on major depression diagnosis, or the severity of depressive symptoms as measured by scales questionnaires. And also which populations target for prevention, the role of risk factors, and the role of interdisciplinary teams in having a protective role of psychiatric side effects. Some alternatives for future studies is to enlarge the pool of symptoms to be targeted in prevention studies, not only depression, but also pain, irritability, fatigue, sleep problems, insomnia, cognitive dysfunction. the development of more specific questionnaires in this specific population, and the definition of risk populations. So let me conclude about some recommendations about prophylactic treatment. A prophylactic antidepressive treatment can be recommended for hepatitis C patients with previous history of interferon-induced depression. Also, patients with depressive symptoms at baseline should also receive antidepressive treatment before starting antiviral therapy, meaning clinically significant depressive symptoms at baseline, depressive disorders at baseline. But patients with subthreshold depressive symptoms at baseline, not clinically relevant, or with a previous history of depression or substance abuse, but currently in remission at baseline, they should be informed about the possibility of a preemptive antidepressant treatment for reducing the risk of developing depression, and individualized decisions should be taken together with the patient and the treated physician. The rest of the population, prophylactic antidepressant treatment is not recommended for the full population of HCV patients. In these patients, if adequate monitoring of psychiatric symptoms is provided, it is safe and efficacious to start antidepressant medication only after the onset of depressive episodes. We can say that pretreatment with antidepressants is well tolerated by HCV patients under antiviral treatment, that pretreatment with antidepressants do not interfere with the achievement of SVR. And we have to say that all previous recommendations are applied only to the use of escitalopram, citalopram, and paroxetine. There are no data available for other antidepressants. And we can choose escitalopram and citalopram as the primary treatment options just because of the lower risk of drug-drug interactions. And also, if antidepressants are used as a pretreatment, they should be continued during the whole course of antiviral therapy, and up to 12 weeks and after antiviral therapy has been stopped. And that's all. Thank you.
Australia, would you start the antidepressant 4 weeks before treatment or on the day of treatment?
Most of these studies started antidepressants 2 weeks before the antiviral treatment. I think just one study started it 4 weeks before. The latency period of antidepressant treatment is about 2 weeks. So, and the latency period when using antidepressants for treating acute depressive episodes during antiviral treatment is even shorter. So we think that 2 weeks, starting antidepressant 2 weeks before, it's enough time for prevention.
Quite simple.
If the patient has a family history of successful suicidal attempts, family history of, and the patient has frequent history of frequent episodes of psychosis, then what will we do?
The question is, if a patient has a family history of suicide, successful suicide, and also frequent personal history of depression, also psychotic level, what would be the recommendation?
Regarding the use of antidepressant pretreatment, we should include these patients in a non-psychiatric risk. They not necessarily are at a risk for developing depression during antiviral treatment. So the recommendation is to monitor them closely and not to start antidepressant pretreatment with them, even if depression is of a psychotic degree. We are not talking about psychotic episodes, pure psychotic episodes. We are talking about depression.
No, if the patient has frequent psychotic episode history, is a real patient, I'm telling you.
The patient with a previous psychotic episode.
Previous frequent psychotic episode and family history of the successful suicidal attempt.
I think, if I can, I mean, a patient like you described probably will be already on some psychiatric medication and will be monitored by a psychiatric team, because a patient like this would require continuous management. So we would expect that if he's well maintained by the current medication, he doesn't need a specific medication on top of it just because he's starting to interfere. Of course, if we're talking about a patient that the moment in which he walks into the hospital is very depressed or is psychotic, at that time, then he will need treatment of the symptoms and then the interferon alpha once the situation is normalized.
One of the contraindications of interferon therapy is also severe psychosis. So, do you think if you are treating with antipsychotic drugs, after that you should be treated with interferon?
It depends on the situation at baseline. If you achieve a stable situation with on antipsychotic medication, you can treat the patient.
So this was shown in several trials that we did, that you can even treat severe psychotic patients if they are stabilized and if they are in an interdisciplinary treatment with a psychiatrist. And there are also some data that psychosis becomes better with interferon. So this is not an absolute contraindication. We do not have any absolute contraindication at the moment. These are relative contraindications which should discussed with a psychiatrist, but such a patient should be treated with a good psychiatrist, good involved in this hepatitis C area.
If I may add to that, I think the last things we want is add the stigma of mental health to the stigma of infection. So I think if people have a mental health problem, even a severe one, if they are within a multidisciplinary environment, they're well managed, they're well treated, all of them have the rights and the clinical possibility to be treated by interferon. So I think that's a message that we'll try to put across very clearly in the guidelines when they will be published. Any more questions?
What about cirrhotic patients? And with regard to use of antidepressant treatment, not only for preventive, but also for the treatment of the depression. So what would you recommend as the recommendation?
Well, usually antidepressants, SSRIs, citalopram and citalopram, are safe in cirrhotic patients. You have to adjust dosage sometimes, but they are safe, so you can use them.
So there's only an increase of bleeding risk if you're really cirrhotic. So you have to monitor this, but this is a case-by-case decision.
Okay, should we? If we don't have.
Is there any of her symptoms with interferon therapy?
Sorry, we couldn't understand. Could you go to the microphone?
No, I have. Is there any euphoric symptom with interferon therapy? Euphoric, so not the breast symptom. Euphoric.
There are some data, as we reviewed at the beginning of the symposium. There are case reports of patients developing mania or mixed affective state during interferon alpha. So it is possible, but it's definitely not as frequent as depression, but it is possible. There is also some case report of mania developed, so euphoria developed a suspension of interferon alpha, so as a kind of rebound rather than doing the treatment.
So we are perfectly in time. We're coming to the last but a very important talk. This is focused on the new antiviral therapy. You know that they're...
And with the new drugs, although they have a great increase in efficacy, the efficacy will really be critically dependent upon patients taking these drugs. And I think it's going to be even more important to make sure that patients comply completely with medication and they understand the importance of taking the tablets regularly. And the side effects that we've been discussing today are the things that are really going to compromise treatment efficacy. So what I'm going to talk about are the new drugs, and I'm going to focus almost exclusively on the psychiatric side effects. Everyone at this meeting is getting very excited with the advent of the new protease inhibitors. And I'm going to talk about telaprevir and boceprevir. I'm going to talk about the effects, neuropsychiatric effects of these drugs, and then talk a little bit about problems with interactions with different neuropsychiatric drugs. Just to remind those of you who aren't familiar with these drugs, these are direct antiviral inhibitors. They kill the virus directly, and we hope they will be launched within the next 6 to 12 months. We're anticipating their launch sometime this year in the European Union. These are the first generation protease inhibitors, the first, we believe, of a whole family of new drugs, and the phase 2 and phase 3 programs are now complete, so we have quite a robust body of data that we can rely on. Sadly, these drugs are used in combination with PEG and ribavirin, so we get all the old side effects of PEG plus ribavirin and something extra. And both of these drugs have subtly but important differences in their side effect profile. With tolaprovir, the major problem is a skin rash. It's relatively minor in the vast majority of patients, but in up to 7% of patients, it's a very severe rash. They also get a little more anemia, and they also get a rather irritating complaint of rectal discomfort. And this drug seems to irritate the rectal mucosa, so patients get a sort of burning pruritus, which is really quite unpleasant. For boceprevir, the biggest problem we see is anemia. There's a little bit more fatigue associated with that, and some strange taste disturbances that make people rather nauseated. This data has been gone through ad nauseam at this conference. I don't intend to go through the trials, other than to point out that tolaprovir, the dosing regime is 3 months of new drug plus PEG and ribavirin, followed by PEG interferon and ribavirin continued for 24 weeks, or a total of 48 weeks. So this is a drug that's only given for the first 3 months. In about 60% of patients, total treatment duration is 6 months. So that means you get 3 months of tolaprovir, PEG interferon, ribavirin, and then 3 months of PEG and ribavirin. And that clearly has a massive impact upon side effects, because that means you're getting 6 months less treatment with PEG interferon and ribavirin, and with good psychiatric support, the symptoms kick in normally within the first few weeks of treatment. Only got to hold the patient's got to be encouraged, motivated to keep going for a total of 6 months. And I think that's going to make life a great deal easier for many of our patients. These are the chief psychiatric problems with tolaprovir. I don't want to mitigate the rash, which is an important consideration. The psychiatric side effects, as you can see, really are pretty much the same as with PEG and ribavirin, with a little bit more anemia. But of course the anemia is only for the first 3 months. When you stop tolaprovir, the hemoglobin comes back up, the fatigue starts to settle. So for the tolaprovir regimes, there are no new psychiatric effects. There are, of course, the continuing problems with PEG and ribavirin, and there's a little bit more fatigue. For boceprevir, totally different treatment algorithm, a totally different approach, with the new drug given continuously throughout the entire course of treatment. And again, a proportion of patients will only need 6 months, getting on for 50% of patients with boceprevir will need a total of 6 months treatment. And again, the psychiatric side effects are predominantly the same as we've seen before. A little bit more changes in fatigue, mainly caused by anemia, because the biggest problem with this drug is the anemia caused by an effect that synergizes with ribavirin. And in fact, in some of these studies, up to 50% of patients took EPO to maintain their hemoglobin. It's not yet clear whether EPO was given unnecessarily, and the EPO was provided free of charge in the trials, so it's certainly possible that EPO was used because it was there, rather than because it was needed. So for boceprevir, it's very much the same as tolaprovir in terms of neuropsychiatric side effects. Nothing new, nothing unique, but perhaps more fatigue because of more anemia. So these drugs do look to be a good addition to current therapy without new psychiatric problems. The big problem that I see, unfortunately, is drug-drug interactions. Both of these drugs are metabolized by enzymes that are widely used to metabolize other drugs. And we are going to see all sorts of rather unpredictable interactions with a wide variety of drugs that we widely use. So, for example, there's the potential for interactions with benzodiazepines. There is the potential interactions with a whole host of sedatives. There is the potential for interaction with a wide range of antidepressants, and including over-the-counter medications like St. John's wort. Now you notice that I said here the potential, and one of the real problems with these drug-drug interactions is they're unpredictable. And the only way to know whether these theoretical interactions are going to be very significant is to do the experiment and put the two drugs together. So we're going to have to learn very quickly which drugs are safe and which drugs might interact and which drugs have been tested. And at the moment, most drugs are in the we don't know category because they haven't been tested. I can't stress enough the importance of getting to grips with drug-drug interactions. Patients need to be aware that if they're buying medication over the counter, they're buying herbal remedies that are quite safe on their own, they may cause catastrophic problems when they're combined with these new drugs. So drugs like St. John's wort, we've been very familiar with, really might cause problems if it's combined with these new agents. I'm a great believer in treating active injecting drug users. I think it's the right thing to do, but I have real concerns about what will happen with street heroin and with these new drugs. The last thing we want is patients getting exacerbations of the sedative effects of heroin and stopping breathing because of unexpected drug-drug interactions. So I think there are real concerns that we shouldn't minimise. The companies are well aware of this, I'm glad to say. There's a lot of work going on to try and address these issues, but unfortunately these studies take time. There are a lot of drugs to test. And at the moment, we're just starting to see some of the interactions being publicised. It's going to be a long time before we know what's safe and what isn't. So the take-home message is very clear. There won't be new psychiatric problems with the new drugs. They're much more effective, and because they're given for shorter periods, patients will have to suffer for shorter periods. And that's a big step forward. The biggest problem that I see is that there will be drug-drug interactions, idiosyncratic, unpredictable drug-drug interactions we're going to have to get to grips with, and we need to get the message out there very quickly that patients need to be very careful what they take in addition to these new drugs, and we really do need to press the companies to getting the information out as quickly as they possibly can. Thank you very much.
Thank you very much. Are there questions about the new antivirals? And
it's lunchtime. Never questions at lunchtime.
So if not, thank you again. Let me finally thank you all for coming here and discussing with us. I want to thank all my colleagues for this lot of work, what they have done. I want to thank again the ELPA for organizing this at Novartis, for financial support for this meeting. So have a good time here in Berlin, and bye-bye.